Hey, this is Jeremy, and today we're going to be talking about strokes. The two types are going to be ischemic strokes and hemorrhagic strokes. Now, regardless of the cause, a stroke is a disruption of blood flow in the brain. It does not matter if it's due to a clot, it does not matter if it's due to a bleed, it does not matter. A stroke is a disruption of blood flow in the brain from the blood vessels. Right? Now, the longer those cells, or the longer that disruption of blood flow is allowed to continue to happen, the more brain cells are going to die. They're going to become ischemic, and then they're going to become infarcted, and then they're not going to be able to participate at all in any sort of neurological function because you have dead brain cells. There's a certain time frame. It's typically about 3 hours that hospitals will allow to gauge kind of how they treat their strokes, or if they're even going to treat it at all. And that's all just kind of dependent on what kind of quality of life can be expected. Now, the fastest way that you can really kind of tell, and it's the big mainstream thing right now, is the FAST mnemonic. And it's F-A-S-T. F stands for facial droop, so does one side of their face drop more than the other? Have they lost ability to control part of their face? A is going to be arm drift. Hold their arms out in front of them, and if one arm drops or one arm continues to drift, as they close their eyes and say, "Hey, are you still holding both your arms out?" They say yes. Well, and then they have an arm drift, and if that arm continues to fall to the side, that's the arm drift. S stands for slurred speech. So it's going to sound like somebody who's really, really inebriated, and that's because they've lost control of part of their tongue and part of their face. They cannot make the same sounds if they could. So F is going to be facial droop, A is going to be arm drift, S is going to be slurred speech, and T is going to be time. The big thing is time is going to be call 911, but with us being 911, you really need to get that patient to the hospital as soon as possible. And what I do is we try to load and go. So identify the stroke, identify what the cause is, and get them into the truck, get them to the appropriate center, or call for a helicopter if it's more appropriate. Alright, so an ischemic stroke, that is due to a disruption of blood flow from a clot. Alright, and that clot is going to be obstructing that blood flow from past that point. It's all kind of dependent on where the clot originates, depending on what actually gets affected. Some risk factors of ischemic strokes: you have AFib, which is atrial fibrillation. So what happens there is the top part of your heart is actually going to cause clots to form inside the atria. And if you have somebody that's not taking their aspirin, not taking their blood thinners, or maybe they have undiagnosed AFib and they've just been living with it, and all of a sudden that clot breaks loose from their atria, makes its way through the ventricle, and it gets kicked up to the brain. That's how that clot gets there. You also have poor dietary habits and smoking. This can cause atherosclerosis, which is going to be a plaque buildup. And this is especially dangerous if you have that plaque buildup in your carotid arteries in your neck. And so if you have somebody that has carotid stenosis or plaque buildup in their carotids, and they can have an 80-90% obstruction, and if that obstruction decides that it's going to break loose, then you're going to cause a clot. And so what you can do is just kind of monitor that. And if you have somebody that has blood disorders or thrombophilia or sickle cell, that can cause your patient to have strokes as well. And the symptoms of a stroke, they're typically of an ischemic stroke. They're typically going to start. They might get a little worse, and they're going to plateau. And what I mean by plateau is they're going to stay consistently that bad for the remainder of the stroke period. Okay, they can improve as soon as you restore some cerebral perfusion, and that's going to be if it resolves itself spontaneously in the field, that's going to be called a TIA, or a transient ischemic attack, and they're going to be given some drugs in the ER that are going to help bust that clot if it's appropriate. So an ischemic stroke patient, they're going to present again with that facial droop, that arm drift, and that slurred speech. The treatment for an ischemic stroke is going to be something called TPA, or a tissue plasminogen activator. And essentially what that does is TPA, it's a protein that's in the body already, and it just kind of activates all the clot busting factors in the body, so it breaks down the clot in the brain. But there is a risk factor if you have somebody that has a recent active GI bleeds or a bleed anywhere in the body. What's going to happen is you've essentially created a bleed that you're not going to be able to stop. Because again, this is something that occurs naturally in the body, and it's just you're given a very, very high dose of it with that TPA. Now, a hemorrhagic stroke is a little bit different, because what actually happens is you have a blood vessel that's inside the brain that actually pops or bursts and ruptures open. This can be due to any number of things. It can be a berry aneurysm that ruptured. You can have a weak vessel from other disease processes. But it's a disruption of the blood flow due to a blood vessel rupture, blood vessel break. So the symptoms are going to progressively get worse. And it's typically going to be described as the worst headache of my life in their moment of consciousness. Because again, it's going to progressively get worse. Some risk factors is going to be uncontrolled hypertension and some blood disorders, such as if you have somebody that is a hemophiliac, so they're prone to bleeding, they have some issues as well. So again, they're going to have the worst headache of their life, and it's going to progressively get worse due to that pressure buildup inside of the brain. And then this is going to lead to an altered level of consciousness. This altered level of consciousness is going to progressively get worse. It's going to, their mental status is going to deteriorate. They're not going to be responsive. They're going to start having posturing, likely decorticate and decerebrate. Look at their pupils. They're likely going to have unequal pupils due to that increased intracranial pressure. And so they're going to present with those signs of ICP or that intracranial pressure, and that's going to be with Cushing's triad. And Cushing's triad is hypertension or widening pulse pressure. And pulse pressure refers to the difference between your systolic and your diastolic. So if you have somebody with blood pressure of 180 over 70, that's a significantly widened blood pressure. But you're really only going to be able to tell widened or widening pulse pressure through a trend of vital signs. And the only way you're able to establish a trend is by having a minimum of 3 sets of vital signs. If that blood pressure continuously gets wider, that pulse pressure gets wider, then you know they have that widened pulse pressure. The second part of Cushing's triad is going to be bradycardia. It's going to put pressure on the sector of the brain that kind of helps regulate your heart function and everything, and all of a sudden you're going to have your heart rate's going to drop, and it's just not going to be working as properly. And then you're going to have irregular respirations, and that's going to be Biot or Cheyne-Stokes respirations. Typically, it's going to be irregular. It's likely going to be slow, and they can have some snoring respirations. And that's Cushing's triad. Hypertension or widening pulse pressure. They kind of fit in that same point. You have bradycardia, and then you have a regular respiration pattern. The ultimate treatment for these patients is going to be surgery. If you were to give them TPA, these patients would continue to get worse and decline. There's going to be significant changes in their quality of life, whether this is their first stroke, second stroke, or and how soon and how rapidly we're able to resolve these issues. You can have somebody that has lost complete function over their left side or their right side, or they've lost the ability to speak. It all just kind of depends on where the stroke actually happened. You always need to check a blood sugar in every single patient that is presenting with signs and symptoms of a stroke, and resolve those issues if they turn out to be hypoglycemic. Hypoglycemia can mimic all the signs and symptoms of a stroke. Right? But remember, ultimately, a stroke is a disruption of blood flow in the brain. Ischemic strokes are clots that cause that disruption, and hemorrhagic strokes are going to be bleeds that cause that obstruction or that disruption. For ischemic strokes, they can give TPA, and for hemorrhagic strokes, they're going to need surgery. Always check a sugar, and just remember that fast mnemonic: F, facial droop; A, arm drift; S, speech, slurred speech; and T for time. All right? That fast mnemonic is going to help you identify those strokes, and it's going to help benefit your patients.